Thanks all for coming out tonight. Sleep difficulties in children with autism is the topic today, and it is, I'm standing right in front of my slides. It is an area that has been really a big area of interest to me, especially in the last couple of years. My degree is actually in school psychology, but I started out in the field in 2000. I actually calculated this. About 14 years ago, in college, I was a behavior technician, and then I worked at Kennedy Krieger as a research assistant in an autism lab. Went to school for school psychology, but it was a very behavioral program. Also got a little training in clinical psychology, and that's where I got my introduction into treatments for sleep disorders in children. Then, moving forward a couple of years, I did a clinical internship at the May Institute, which is an ABA treatment center where kids come from around the country. Following that, I was a BCBA at Boston Public Schools and did my postdoc last year at Riley Children's Hospital in their Autism Treatment Center. And there I was doing outpatient behavioral treatment for families with autism. And this problem came up again and again and really became really an area that I'm very, very passionate about because, as you know, and as I'll talk about, when an individual with autism has sleep problems, the entire family is affected. And the good news is that there's treatments available, and I'm really excited to share those with you today. So let's get started with a little bit of an overview. So I'm going to just talk to you a little bit about the basics of sleep, how it works. I'm going to describe the importance of sleep, but you guys, you know the importance of sleep. Then I'll talk about sleep problems and the kinds of sleep problems you're most likely to see in children on the spectrum. Talk about how we assess for sleep problems, and talk about preventative strategies, which I'm really passionate about because we can actually knock out about 75% of sleep problems just with good prevention alone. And then when that doesn't work, we'll talk about some interventions as well too. I highlighted the bedtime pass. It's last, but because I'm a psychologist, I understand the recency effect, meaning that sometimes the last thing we present is going to be the thing that sticks in your head. So I want to present what I think is probably the easiest intervention and that I presented materials to try stuff for. I'm going to present that last so it sticks with you. And then I'm going to share some resources with you. I've already printed out a whole bunch of resources that you can take home, but I'll also share some books that I found just truly fantastic and talk about where you can get more help and more support, and then hopefully leave some time for questions and answers. Just a little note that this training is for educational purposes. We have to say this as psychologists, by the way. So this training is for educational purposes. It does not take the place of individual treatment. I haven't met all of you or your children yet or assessed them in order to provide individual treatment options. So let's get started. Just a little bit about sleep. There are several major theories of sleep, but the one that I keep seeing the most support for is that sleep serves a restorative function. And that makes good sense to all of us, right? So we know that sleep affects both cognitive and physical processes, things like your health. You're less likely to get sick if you are if you're sleeping well. You're less likely to be irritable. I am so irritable when I'm sleep deprived. We also know that it's really important for learning and memory, particularly one type of sleep, which I'll get to in a minute. Is anyone familiar with the term rapid eye movement, REM sleep? That type of sleep tends to be the most important for learning and memory. And if we're not getting a full cycle of sleep, we're missing out on REM, so we're missing that time where we're really growing and learning. So that goes to say, my slides were advancing on themselves, but that kind of skips ahead to say that sleep is actually an active process. Although we're not conscious, we're not fully conscious, our brain is really hard at work. Sleep is driven by two main drives. One is circadian rhythms, so I'm sure that term is familiar to some of you. It basically means your biological clock. And two things I want you to know about your biological clock, two things that affect it are light exposure and natural production of melatonin. And melatonin, are you all familiar with that? so you can take melatonin supplements, but our brain also naturally makes melatonin. And so the light production, the light exposure actually is one of the factors that ties into melatonin. And then there's what we call the homostatic drive, and this is a buildup of factors. This is like accumulation of factors. Did you sleep well the night before? Okay. Did you nap? Okay. Did you consume a lot of caffeine? Did you exercise? And then, like I said, it skipped past me, so I already talked that it's an active process. And the way that scientists study sleep is by hooking your brain up to electrodes and measuring the electrical activity. So the scientists that do this have discovered that there's about 4 phases of sleep. You have the non-REM sleep, which are light sleep, and deepest sleep. And then you spend another portion of your night in REM sleep. Like I said, that's the most important type of sleep, it appears to be. That's also when you dream. And if everything's working well, that's when you're not running around. Your motor system should shut down at that time too. Doesn't always for everyone, but that's what should happen. So how much sleep should your child be getting? This is the latest recommendation from the National Sleep Foundation. They've recently adjusted to make it more of a window because they recognize that your individual needs may vary. Even with this doesn't, just because it's up here does not mean that this is the amount that your child needs. This does not take into account children with autism, and there's been some research. I haven't seen the numbers yet, but there's been some research that says that they may have different sleep needs. They may have less sleep needs. So just take that with a grain of salt. This is how many adults do you know that actually do get their recommended 7 or 8 hours a night? This is what we strive for. Just putting that up there as our aspirational goals. I know I personally get about 6 and have to say, okay, that's a good day for me. How common are sleep problems? They're really common, not just among kids with autism, but as you see looking at these numbers, especially common with kids with autism. It's actually more likely that you're going to have this type of problem with an individual on the spectrum than not. But it's common enough that about 30%, about a third of us have sleep problems, both as children and as adults. But this is where I'm really concerned, right? Because you as parents of special needs children, you need more coping resources, right? Your needs for time are quite different. And so if they're not sleeping, you're not sleeping. And that, I'm sure, is why you're here today. I apologize, I was just editing my slide. There's actually 3 causes here. One is medical. Yeah, so that got bumped over. So that should be, oops. This one should actually be its own little bullet point. So first is what I kind of refer to. Some people have biological differences in neurotransmitters and melatonin and things that affect sleep. So there are some individual differences that may make some people have some really noticeable sleep differences. For example, about 10% of the population is like myself, what we refer to as sleep owls, or I'm sorry, night owls. I wish I was a sleep owl. Yeah. A night owl being someone that stays up really late and I work really well really late, but the problem is, right, and as I'll kind of go into, I know that I'm setting myself up for failure because if I'm working late, I'm stressed out, even if I'm not stressed out, I'm thinking about things, then it's harder for me to unwind. So we want to kind of take that approach too with our children, and I'll get into that. So first is biological, next is medical causes. Anytime someone came to me at Riley and said I had sleep problems with my kids, the first thing that we were saying is, okay, have you done just a physical yet? Because it's really important. I had a family and they had 2 kids on the spectrum, both of which having sleep difficulties, and one behavior from one kid was set off the next kid. Parents weren't getting any sleep at night. Our psychiatrist on staff was excellent and said, okay, well, first let me do a little workup medically before we even address this behaviorally. found out that there was sinus infections, they needed their tonsils removed, and they had acid reflux. So you try to sleep with all that. So it's really important, especially among children that are nonverbal or minimally verbal, or even among the more verbal children, they may not really be able to describe it. It's a hard process to be able to describe internal pain. So it's really important that you get a medical checkup, just to make sure that all normal processes are working okay, and address medical needs too, because those can certainly impact sleep. So some potential medical issues include just general pain. A lot of children on the spectrum also have GI issues, GI issues, that's another story, that can, like acid reflux, which can certainly impact sleep. Also, sleep apnea is something to consider. We won't go into that today because that's a little bit more of a medical cause. Dental issues, and then psychological issues like anxiety and depression can also impact sleep. And then what we're really going to focus on today is the behavioral environmental causes. So this is poor sleep hygiene, and I'll define that in a couple of slides. And inappropriate sleep dependencies. But the good news is that if your children have these bad sleep habits, they are fixable. So what are effects of sleep deprivations on the child? Rather than reading my slide, what are some of the things that you guys see when your children are really sleepy and tired all day?
They fall asleep when they're supposed to be like in class.
Uh-huh. That's actually my picture.
Yeah. So they get probably grumpy and more meltdowns.
Absolutely, more meltdowns. It's kind of the chicken or the egg problem, which causes, is it the behavior problems causing the lack of sleep, or is it the lack of sleep causing behavior problems? So when we at Riley did our outpatient treatment and we had a limited amount of time with the family, we actually targeted sleep before behavior problems if there was a lot going on, because by reducing by increasing sleep, we may be addressing some of those behavioral problems. But as we know, as I've already said, we really have to consider the effect of the sleep deprivation on the family too. Of course, this has side effects for your work, for your other children's school, your ability, diminished coping skills. I hate to think about how I treat my husband when I'm really cranky because I'm tired. And that can cause family stress as well too. So what are the most common types of sleep problems? We have insomnia, and I'll break that into two parts. The first is just difficulty falling asleep. And for some kids, this is expressed as bedtime resistance or tantrums. For others, it's expressed as just lying in bed awake at night. Some potential causes are anxiety and depression. So technically, that's not considered insomnia. It will be insomnia secondary to anxiety and depression. So when that happens, it's important to work with a psychologist to treat, or a psychologist and psychiatrist to work on addressing those issues as well too. Some other potential causes are poor sleep hygiene, which we'll talk about today, and like I mentioned, potential biological differences as well too. So we have difficulty falling asleep, and then we have difficulty staying asleep, which is waking up in the middle of the night. We also have kids that wake up too early. I've worked with a lot of families that their kids are up at 4 a.m. and they don't want to be up at 4 a.m. Yeah. And I can see by your heads that a lot of you are experiencing that as well too. Some other sleep problems that we won't get into today, but certainly do occur: nightmares, sleep terrors. Has anyone here experienced sleep terrors? So sleep terrors occur in about 10% of children and about 5% of adults. It tends to go away as children age. They're really scary because they act like they're being attacked. However, if you wake them up, they have no memory of it. So it's not detrimental to their health. It just looks really scary. The reason I'm talking about that is, and kind of pointing that out, is because some of the interventions that I'm going to talk about, a rare side effect can be sleep terrors. So if they happen, know that they are not harmful. They're just scary to watch. Ooh, this really wants to advance on me. So also, I swear that I'm going to put it down for a second. So some other problems are sleep walking and sleep talking, tooth grinding, delayed sleep phase syndrome. So these are people that are beyond night owls. These are people that are awake at totally the wrong times. And then you have your breathing related problems like sleep apnea, hypersomnia, kids that sleep all the time, and then narcolepsy, people falling asleep while they're supposed to be awake, and then things like restless leg syndrome. The most common types that we see among kids on the spectrum are definitely difficulty falling asleep, difficulty staying asleep, and waking up too early. So how do we assess for sleep problems? Again, you want to first rule out medical concerns, but then the next step is to do a questionnaire. We really want to figure out what type of sleep concerns are the issue so we can develop treatments specific to that issue. So the way to do that is to fill out a screener. So the three that I like are the Albany Sleep Problem Scale, the BEARS, the Children's Sleep Habits Questionnaire, and the FISH, the Family Inventory of Sleep Habits. So I'm going to jump the gun a little bit and recommend these two books. This is Sleep Better by Mark Durond. He is the foremost expert in children with special needs and sleep. He's been in this field for over 30 years, and most of the information I read from anywhere else refers back to him. This one was just updated in 2005, and it is a fantastic book. Most of the stuff that I talk about is covered here in more depth, and some of the stuff that I'm not going to get to today is covered here. The reason I'm bringing up this now is because the Albany Sleep Problem Scale, okay. It's just possessed. The Albany Sleep Problem Scale is in here, and it has a little guide to interpreting it. And then the other one, which is solving sleep problems in children with autism spectrum disorders, a guide for frazzled family. They refer a lot back to this book, but it's a little bit of a shorter read. And they have the other three questionnaires in here and some guides for interpreting it. So I definitely recommend, if you're having difficulties, if you're here, these are some really great resources, and I'll leave them up if you want to flip through them. So the next step is to complete a sleep log or sleep diary for about a week. Just to figure out what the problem is, you may want to continue doing that to figure out whether your intervention is working. To have, this is kind of like a baseline, and then you might want to do it when you start treatment too, to have kind of notes to compare, hey, are things getting better? Because sometimes you might make small progress that you might not otherwise notice. The small progress will add up though, and that's why it's important to log it, because you don't want to give up too early if you're making small progress. I'm just going to be battling with this. Okay, so when you're doing a sleep log, there's a couple different forms for them. The key information that you want is the time you put them to bed, then the time they actually fall asleep. Those are two drastically different times for a lot of families. Nighttime awakening, so what time are they waking up and how long are they awake for? What they're doing during nighttime awakening. Family that I worked with last year, this goes kind of jumping up and down on sleep hygiene for a little bit, but if they do wake up, you don't want them engaged in stimulating, rousing activities. So playing games and watching TV is probably not going to help them get back to sleep. So it's important to note those kind of activities because we want to think about what we're doing when they do wake up in the middle of the night. And then the time they awake in the morning, and if they've taken any naps, because again, that all comes into play on the next night of sleep. Okay, so how do you treat sleep problems? I love seeing this research that parent education alone is effective for many parents. So the studies that I have read talked about 1 hour of individualized parent education or 4 hours of group education being effective in making some at least about 30 minutes to an hour difference in terms of the total sleep duration and how long it took the children to fall asleep. And then, as I mentioned with my books, another good avenue is to become educated through the use of books that kind of focus on it. And again, these are the two that I really recommend. And then of course, if you can't, trying it yourself is all well and good, but what happens when you run into problems? Well, there are psychologists out there and some behavior analysts or doctors with training in treating sleep disorders. I know, I don't want to keep saying Riley, it's not an official endorsement, but that's where I did my postdoc, and I know that that was part of my training was in this. So I know that there are professionals there, and I think at St. Vincent's as well too, they do have some professionals.
How well is that able to work with nonverbal children?
So we'll talk about that. There are a range of different strategies that go from verbal children to nonverbal children.
Okay.
And then there are, of course, medical treatments as well.
Yeah, I'm just wondering about, the therapy with nonverbal kids. That's...
Oh, you mean at an outpatient?
Yeah.
It's a little bit more difficult on the outpatient level.
Yeah.
Yes, you are completely right. But there are still some, so what I did there was mostly giving parents basic behavioral principles to use. Okay, so this is what the functions of behavior are. Kind of giving them a little bit of tools to help reduce some problem behaviors. We're not doing an outpatient therapy. We're not doing full-fledged ABA like we have in centers here. So it's mostly, I have a problem with this behavior. Okay, let's set up a plan.
Good.
Okay, so here are just some recommendations before you start a sleep program. So first, begin with sleep hygiene, and I promise next slide or the next two slides will actually define that. Because 75% of sleep issues can be addressed by solving these sleep hygiene or sleep habit factors. And then if you have both of the main types of problems, which are difficulties going to bed and waking in the middle of the night, start with bedtime first, because sometimes if you start there, well, many times when you start there, you can knock out the nighttime awakenings. Not to say that you might not need both types of interventions, but Mark Durond, who I trust more than anyone, says start with bedtime, and I believe him. He says start with sleep hygiene and a good bedtime routine, and then start with bedtime. The good news, too, is that there are multiple treatment options for each type of problem, and that's something I really want to emphasize, and that's something that Dr. Durand emphasizes as well, too, is finding an option that will fit with your family, because there are pros and cons of each type of treatment. So, for example, some treatments may require you to ignore tantrums or crying, and your level of ability to ignore that may be good for some kids and may not be good for other children. And then other interventions may require you to stay up later, at least while you're getting the intervention going. So there are options and there are pros and cons to them, but know that there are different options. So if one doesn't work, you could potentially try another one and find the one that works best for the context of your family. It's really important, too, that when you make a commitment to start the plan, you make a commitment to start the plan, meaning don't do it if you have a busy project at work or something like that. Find a time where you can really say, I want to focus on this for the next couple of weeks. If this seems overwhelming, start with one small change and then go on from there. And then be patient. Some of these interventions will work immediately, and others may take 2 to 3 weeks in order for you to see the effects. So keep a strong chin and kind of soldier through, and I'll kind of try to explain, I think I have in my presentation, which ones may be a little bit quicker than others. And then finally, recognize that you're not going to be perfect. Nobody is perfect. There are going to be times where even if you do adequately address the sleep problem, someone's going to be sick. You're going to be on vacation. You're going to be out of town. Sleep is going to get disrupted again. That's fine. No one's going to be 100% perfect. When interruptions happen, when your schedule gets more back to normal, just start the intervention again. Usually, if you have to start an intervention again, you don't have to do it for quite as long the second time around. And then don't give up if a plan doesn't work. If you're trying some of these plans on your own with the help of some self-help books and it doesn't work, some of these issues your team supervisor may be able to help you address. or you may need to seek out additional treatment. It could be just one small change that will make the difference. So don't give up, don't get discouraged. There are lots of families out there that have these issues, and there are treatments out there that do work for most families. So finally, we get to describe sleep hygiene. So I came up with my own definition because there's a lot out there. So I defined it as developing healthy sleep habits, eliminating the factors out there in the environment that are going to interfere with sleep, and then establishing healthy sleep associations. So basically, we want to establish as many positive associations with sleep, and we want as many things to be queued up and associated with sleep as possible. And we want to figure out what are the healthy ones to establish. So when, for example, we want the bedtime to be, or we want the bed to be associated with sleep and sleep only. We want that to be a cue for the child to sleep. So we want to develop as many of them as possible. And we want to have these factors, these cues, if you will, present both at bedtime and if the child is waking up in the middle of the night. We want those same cues to be there. We want these set of conditions to mean, hey, it's time to go to bed. And like I said before, sleep hygiene is always the first place to start because it can address many of the difficulties. And then as I'm going to go through these factors, just a little caveat, what affects one person is not going to be the same as the other. So for example, I'm going to talk about television and screen time. That really impacts my sleep. My husband can't go to sleep without it. But if you are having problems with sleep difficulties, try as many of these things as possible because these are all factors that have been found to be associating with sleep difficulties. So hit as many as you can. Okay, developing good sleep habits. The first is you want the actual time of day itself to be your primary cue. Okay, it's 8 o'clock, it's 9 o'clock, I'm tired because that's when I always go to bed. This is where it's actually, children with autism, their assistance on routine is actually helpful, right? We want it to keep bedtime as consistent as possible so that time itself is a natural cue. And that means that even on weekends, we keep bedtime pretty much at the same time. Okay. Even on weekends, we keep bedtime pretty much at the same time. It's okay to vary by a half hour or an hour. But it's also important to know that when you want your child to go to bed, it may not be the time that they're ready to go to bed. The important thing here is to keep the same time each night, and we'll talk about that. Lisa, I need my alone time. I cannot have my child running around till 12 a.m. So this is really where you can work with your team supervisor to develop some quiet, independent routines that your child can do by themselves. And I'll talk about that a little bit more later. So when is a good bedtime? Well, first determine when your child has to be awake. Then look at those sleep recommendations. We're probably going to aim for the bottom window of that, and then start working backwards to help determine what might be a good bedtime. And then really play around with it a little bit. If you hit those numbers, your child is still drowsy, increase it by a little bit. The factors that you look at are, is my child falling asleep within 15 minutes to 20 minutes? And how difficult is it to wake them up in the morning? You know you're getting a good night's sleep and you've hit the right time when you're falling asleep within about 15 to 20 minutes and you're easy to wake in the morning. So, since my slides have already advanced, keep a consistent wake time. So again, we want the bedtime and the time that you wake up to be consistent. And this is important even when your child didn't sleep well the night before. As parents, you want them to get that extra sleep. But it's actually important that they are tired because then being tired helps them to go to bed that next night. So that goes along with naps, right? If your child is sleepy, it feels like a good idea to let them nap, but then that can really impact sleep that night or the next night. If you can't completely eliminate naps, the magic window is no naps after 4 p.m.
So are you talking like 15 minutes? Are you talking an hour?
Well, the more sleep that you get, the more it's going to be impacted. We would say any naps. However, again, your mileage may vary. If you need a 15-minute nap, there's really, a 15-minute nap isn't going to throw things off too much, so long as you get, so exercise and sleep. We know exercise is really important for sleep, right? But when you exercise is also super important for sleep. Physical activity or stressful activity too close to bedtime interferes with sleep. The best time to exercise is about 4 to 6 hours before bedtime. This is because when you're exercising, it raises your body temperature, and when we are sleeping, like a natural biological sleep cue is that your body temperature drops as you're drowsy, and so it takes naturally about 4 to 6 hours once our temperature is raised to drop. So the best time to get that burst of physical activity is 4 to 6 hours before sleep. And then kind of going along with that, eliminate stressful activities before bedtime. So for example, most people have brushing their teeth as part of a bedtime routine. However, if that's a really stressful activity for your child, don't do that in the hour before bed. The other thing that you want to look at is screen time. There's been a lot of research out there that says for everybody, there's something about these backlit screens, cell phones, TVs, computers, tablets, that interfere with those naturally occurring electrical activity, those kind of sleep waves. So it does make it harder to go to sleep when you're watching something. So one of the first recommendations that I have for parents is to take away tablets and cell phones in the hour before bed. So also be aware of how sleep, on how food and caffeine impact sleep. We know that some children are really caffeine sensitive. Some children really can't have caffeine at all, but the general recommendation says kind of that magic 4 to 6 hour window. Don't give them soda for dinner. And beware of times, I mean, that makes sense, right? But some kids are so sensitive that even things like chocolate milk in the hours before bed, it has small amounts of caffeine, but for some children they're more sensitive, and even those small amounts can affect.
Actually, it's weird is I've got my one child, if I give her caffeine, it puts her to sleep.
There are, you know, like I said, same thing with Benadryl, right? Most people get really tired, and it's used as a sleep aid for most people. There's a small percent of that population where it has the opposite effect. So caffeine could be like that too. A healthy diet, that is a whole other topic, right? That's another thing that I volunteered to do. But what I want you to take from this, right, is that eliminate spicy foods or gas-producing foods around dinner or bedtime. But we know that kind of old, you know, grandmother's advice, drink a glass of milk before bed, that actually does help. Because milk has tryptophans in it. You might have heard of that like from Thanksgiving and turkey. Milk actually has a little bit more tryptophans, and so it does make you a bit tired.
So are there other non-dairy tryptophan options?
I don't know off the top of my head, but yes, because turkey's one, but I don't know other than that. Quick Google might help you find that out.
That's a good Google.
And then also consider what medication your child might be on, particularly things like ADHD, allergy, and asthma medicines, epilepsy, and antipsychotic medications. I'm not saying get your children off of them. I'm not saying that at all. But talk to your doctor and let them know that sleep is an issue. Your doctor will work with you to make that decision, whether it's the dosage that needs to be varied, the type of medication, or the timing. Or maybe not anything at all. Maybe, you know, the problem is so severe that it trumps the need for sleep, but it's just something to consider. So, developing a comfortable sleeping environment. So the first thing to consider is lighting. And when I'm talking about this, guys, know that kids on the spectrum, they do have a lot of them have sensory abnormalities. So even things that, I think I had that little detective guy, yeah. So you want to be detective to try to figure out what sort of sensory things might be going on that might be distracting your child from ability to fall asleep. So lighting, the bedroom should be dark, although, you know, we're kids, night lights are okay. But think about things like, is there a bright street light that personally bothers me a lot too. For a child with autism, just a little bit of light out coming through the door may be actually quite a big deal for them.
Now my son is like, even for as old as he is, he's never over there because he freaks out if the room is dark.
And that's
So
why night
even
lights
if I
are
do-
quite okay.
yeah.
So
I've
if you
been trying
can't
to do the night light, but he just, it's not enough.
So if you can't do night lights, just keep dim lights. Because the more bright light exposure, the more kind of that triggers the awake. But dim lights, a lot of parents have told me things like that. And so just keep lights dim. But looking at the biological clock, light can be great, but it's when you get the light. So the sleep researchers out there say that get bright light exposure the first thing you can in the morning. That's going to help your circadian rhythms and your natural biological clock. Then think about noise. I'm a sensitive sleeper, guys. As is my mother, I've always had one of these in my life. This is the old-fashioned noisemaker. I have recently, in the last year, upgraded my mother to an app. This is a noise machine app. I never use the rain, thunder, that's distracting, but they have some good white noise ones as well too. And what I like about that is, I remember vacations with my mother, we always had these, half of our suitcases were taken up with these sleep aids, right? So now, wherever we go, we have it on our app. Temperature is important too. Different people have different preferences, but it's better to go to bed a little bit cold and to kind of snuggle up than it is to be too hot.
Portland's good.
And then to consider some other sensory issues. There are definitely children, I was going to say, you know how a lot of children have food things that, textures have to be right. A lot of kids have textures of and arrangements of the bedroom pillows and the blankets have to be the right texture, so look at that as well too. Right, and getting in kind of that tight, confined space. Some children, I had a child once that would only sleep in a cardboard little box cave that they made so they could get that sensory tightness. Hey, that's fine. That's as long as the parents could take that with them if they needed to. Hey, I'm okay with that sleep association. So I think I was talking about this earlier. You want to associate the bedroom with sleep, okay? A lot of us don't have the luxury to reserve the bedroom just for sleep. So the recommendation is if you can't reserve the bedroom just for sleep, reserve the bed just for sleep. And I've gone so far as, so for example, I had a child that I was working with last year that associated the bed with a place to jump. So we took out the top. He was on bunk beds, we took out the top mattress and then had to put the bottom mattress on the floor so it no longer gave him the jumping sensation. We want our beds to be not a time where we're playing, not a time where we're being punished, but only associated with sleep. For adults, the recommendation, and I do this, it's bad, but don't work in bed. They say that you should restrict the bed only for sleep. If you find your child or yourself even in lying awake in bed and you're awake for a long time, get out of bed because you don't want to associate your bed with the lack of sleep. You want to associate it with sleep. So get up and do something that will, do something boring for a couple minutes. I've seen anywhere from 15 minutes to an hour, and then try to go back to sleep. Another thing to consider too is if you're in bed and lying awake, make yourself more tired by making your bedtime a little bit later. So also consider what, where, who. I think I have all the W's in there, maybe missing one or two. What your child needs to fall asleep. So if they're falling, what I'm trying to get at here is if they fall asleep on the couch, right, and then you're there and stuff is going on, and then you move into the bedroom, then they wake up and things are really different. That's a different sleep association, so conditions are different. You want conditions to be really, really much the same as when they go to bed as when they wake up in the middle of the night. So avoid letting them fall asleep other places. If you notice that they're getting drowsy and you're not working on one of the interventions that make them drowsy on purpose, get them to bed. And then find self-comforting objects. This one brings a smile to my face because this is my sleep comfort item that my mother used with me. She made a mistake, guys. She only had one, and when she got a spare, she got it in another color. So then I wouldn't sleep unless I had both colors. So I recommend that when you do develop the healthy sleep associations, don't buy one, don't buy two, buy 5, and hide them so that you do have backups for when you need them. The good thing about this is if this is associated with sleep and not you, okay, that can help your child go back to sleep alone rather than having you be the sleep association. So bedtime routines are another really important factor of sleep hygiene. So depending on your child's functioning level, you want to start the routine 15 minutes to 30 minutes before bedtime. Oh, I'm going to grab something out of my office in a second too because I actually made one of these. Okay, sorry. So you want to choose 3 to 6 relaxing or sleep-related activities to put on your sleep schedule, to put on your sleep routine. So things like washing, reading a book, listening to a story, having a bath rub, things like doing a puzzle or drawing, maybe calming for some children. And again, like I mentioned, anything that's stressful, you want to take out of the sleep you want to take out of that part of the schedule, put that earlier. And then arrange the activities. So for example, you start out with your snack in your kitchen, then you go to the bathroom and you brush your teeth if that's not something that causes stress, and then you go to your bed. So they should be oriented towards the bed. And then for kids on the spectrum, we don't want to introduce rigidity, right? So have a good solid routine but make slight variations, build that in from the start. Visual schedules are pretty much the way to go, and I'm going to talk in the next slide. It has 4 different visual schedules for differing levels of functioning. Visual schedules are really important because they help kids understand the routine. And I'll show you the 4 different types. When you are using a sleep schedule, you want to pick a cue like time for bed and what's next, and use those cues consistently because those cues itself can become a positive sleep association. So when you're introducing a schedule, you may initially have to physically prompt your child to use the schedule. We recommend that you stand behind them and help them to do it. And if you need to, when you, many children, especially those that have been here, may be able to do this independently. But if not, you may have to teach it by physically prompting them and then rewarding them for completing the schedule. So here are some 4 different types of sleep schedules. So one is objects. So you take the object to the location that you need. Okay, so that one would be used for our lower functioning students. Then we have a visual schedule, and then we move up to a visual and written schedule. And finally, for our older kids and kids that are able to read quite well, you can move to a checklist. Let me go grab one. Sarah, would you mind looking on my desk for my, it's on a clipboard, so I can just show you an example. And I also want to refer you to the handout because this handout has the instructions for making a visual schedule, and it has a whole bunch of pictures that you can use. If you don't like these pictures, talk to your team supervisor. They can help you make something like this. Thank you. So I didn't put these, I ran out of time today. I didn't put them in order, but essentially it would go in order. This one has a little too much going on. I would say 3 to 6, so something like that, right? You want it again to move towards the bed. As they complete it, they put it in the back. They pull it off and put it on the back. So this is something that we were able to make in just a couple minutes. And again, if you need help, ask your team supervisor. We can certainly help you make one. Okay, so now moving on to strategies for bedtime. And guys, I think I might run a little bit over, so if you would please save your questions for the end so I can make sure that we talk about a bunch of different strategies. So strategies for kids that don't want to go to bed. Again, sleep hygiene is the way to go first, especially using that bedtime routine and using a visual schedule to help with that routine. In terms of if that doesn't work, there are 2 research-based treatment options. One is called modified extinction. You might also hear this referred to as graduated extinction or the check-in method. And the other one is called bedtime fading, also sometimes called sleep restriction. So modified extinction. After you put the child to bed, you ignore any sort of verbal protest or crying for a set amount of time. and then you check in with them, and you systematically increase the amount of time you're willing to wait before checking in. Bedtime fading is you temporarily, basically you want the child to go to bed super tired and super compliant. So you move bedtime later until you find the right time where they go to bed super tired and easily, and then you start fading that time back earlier and earlier gradually. So now I'm going to give you more detail about each of those two options. So for modified extinction, you first establish a consistent bedtime, and then you determine how long you as parents are willing to wait and feel comfortable waiting before checking in. Then you want to start on a night where it's okay. You know that sleep is the first night's going to be a little rocky, so we recommend Friday night as being a good night for most families. So on the first night, after you do the bedtime routine, you put the child to bed at the established bedtime, then you leave the room and you wait for that period of time that you've already selected. So the child starts crying. If the child is still crying when that time is up, then you go in briefly, you check on them. Don't give them a ton of attention. Don't give them a snack. It's just a brief check-in. Okay, I hear you. You need to go back to bed. What you really want to be aware of is engaging in too much conversation or engaging in arguments. It's just a brief check-in, and then you're going to wait the same amount of time the next time they wake up. When you feel comfortable, you can do this within the same night, or you can wait for the next night. When you feel comfortable, then slowly increase the amount of time. You can do this as much by, I've had people do this at 30-second intervals if they needed to, all the way up to, okay, I'm going to do 10-minute, I'm going to increase it by 10 minutes at a time. So play around for what works with you and what you feel comfortable with. And you're just going to continue to gradually increase the time between check-ins. Well, that's way too fast. Until the check-ins are no longer needed. Stop. Okay, bedtime fading. So with bedtime fading, you're using that sleep diary that I referred to earlier, and those two books have some good ideas for making a sleep diary. You want to determine when your child is likely to fall asleep on their own. So that may be 2 a.m. It may be, let's say on this example, it's 12:30. You're going to add a half hour to that time. You're going to find around the average time that they're falling asleep right now, and then add a half hour to an hour to it. So they, again, the goal here is that they go to bed super tired. So 12:30 plus 30 minutes, 1 a.m. would be the new bedtime. So if the child is falling asleep easily, again, that's about 15 to 20 minutes for 2 consecutive nights, then you're going to start moving bedtime 15 minutes earlier. Now, it's important when you're running this intervention that the child is kept awake even if they seem drowsy. And it's important, too, to maintain that consistent awake time. Because remember, again, the whole purpose of this intervention is to make your child drowsy so they go to bed compliant because they're so tired. If when you're doing this, your child is not falling asleep within that 15 to 20 minute period, have them stay up, do something like a puzzle or read a book, something calm. And if this occurs for several nights in a row, consider moving bedtime back even later. So as you have those consecutive nights where they're going to bed without problems within 15 minutes, you're going to keep bumping back bedtime in those 15-minute intervals until you reach your more desired bedtime. So, okay, I'm just gonna, nope, not. Sorry guys, this worked fine before. Okay, so comparing those two options, some of the advantages of the modified extinction method is that you do get to keep the normal bedtime and you don't need to adjust your personal schedule. You can check in on the child. Some parents feel more comfortable with that option, and it typically starts working in about a week. The difficulty factor is that it may be too difficult to ignore their crying, and beyond that, it may not be safe to ignore them. If they have dangerous behaviors, this is probably not the intervention choice for you. Also, anytime you're using any sort of planned ignoring strategy, I'm not saying that it happens all the time, but you can see a temporary increase in problem behaviors. Just know that it can occur and write it out, because typically it is just a temporary increase. If that increase though does become intolerable, switch to bedtime fading. And so some modifications, Dr. Durond talks in his book some more about some different strategies for when you try this and it doesn't work. But one potential modification you can make is if the parents can't wait for the given check-in time, you know, your child is like really disruptive and you want to go in there, it's really more important to be consistent on that night and to keep that interval consistent, because you want the time to control your check-in and not the child's behavior. Does that make sense? Mm-hmm. Okay, and then for bedtime fading, this is more of what we call an errorless approach. It doesn't typically involve increase in problem behaviors, at least at bedtime. If they're drowsy and tired throughout the day, you may see just an overall small spike in problem behaviors, but you're going to avoid the bedtime struggle. Some disadvantages is that this one impacts your sleep, so you have to be committed to do this, knowing that it's not a permanent change to your sleep. You're working towards improving your child's sleep. It does require you to be awake later at night, and it can take several weeks to work. As I mentioned before, with this intervention, because you are restricting their sleep, you may see a temporary, and it's rare, but it can occur in other sleep problems, walking, talking, and sleep terrors. Again, these aren't harmful. A lot of children have these problems. Just know that it is a potential side effect. And then one potential modification is if you absolutely can't keep the child awake, they are just falling asleep left and right. Hey, that's great, okay? That means you can move bedtime a little bit earlier if they're doing that consistently. So options now for staying asleep. There are actually 3 options, and I'm going to cover 2 today. So one is sleep restriction. It really is the same concept as bedtime fading. You're making them more tired, so they're more likely to go to bed. To do this, you'll use that sleep log to calculate how long on average your child is actually sleeping, not in bed, but actually sleeping, and then restrict this to about 90% of the amount. If possible, you want to do this by waking them up earlier in the morning. I'm not a morning person. I would not do this method. It's the preferred method, but if you can't wake them up earlier, let's say they're getting up at 4 a.m. anyways, okay, it's okay to move bedtime instead. Same thing with this. If you see, as I mentioned before, if your child is lying in bed and not sleeping, after a while, get them up, get them doing something boring before trying to bring them back to bed. So when using the sleep restriction, if nighttime awakenings decrease for about a week, then it's okay to adjust bedtime or waking schedule. This one you want to do at about 15-minute intervals as well too. And then you want to repeat these steps until you achieve the desired sleep schedule. This has similar advantages and disadvantages to the bedtime fading method. It's pretty similar. The other option, again, is modified extinction. It's the same thing, except for instead of starting at bedtime, you start when your child wakes up in the middle of the night crying. If your child is getting out of bed, I will talk about that in a little bit in more detail, but you can still use modified extinction. You would just bring them back to bed without a single word. You bring them back to bed, and that's when you start your check-ins. Option 3 it is a little bit more complex, so I'm going to leave that to Dr. Durond if you are interested in his book. But generally, the principle here is actually a little bit different than it doesn't quite make intuitive sense. But basically what you do is that you figure out when your child is likely to awake, and you gently nudge them like half awake. And that we don't know exactly how it works, but it seems to reset the sleep cycle. So again, I'm going to refer to Dr. Durond if you wanted to try that intervention. So there's actually 3 strategies that you can try here. So a word about nighttime safety. Some of our kids, we do not want them wandering the house at night. So at Riley, we recommended the use of a door alarm for those children, so at least parents would get up. And then you can pair that with some of those other things. You can do, okay, I know my child's up, now I can do my check-in, my check-in or modified extinction methods. Another strategy too is to use something like a Dutch door. So you can, basically the thing is you don't want to lock the children in the bedroom. What if there's an emergency? You want to make sure that you can maintain eye contact. You could use like a peephole or a Dutch door. If you find that they're getting up at bed at night, you still want to have that good visual on what they're doing if they're engaging in dangerous behaviors.
And
But
the problem now is that my son insists on locking himself in his room, so.
that's a different problem. And that
Yeah,
might
that's
be
a different problem.
uninstalling the lock.
Yeah. Can't really do that.
So getting children to sleep alone and then leave you alone, hopefully until morning. Okay, so this one, it might start playing as I talk about it, but this intervention is something that I actually used a lot in grad school when I was working in a pediatric outpatient, just general psychology clinic. This one actually works better if I show it to you. So essentially what happens here is that if you're not, okay, right, you're addressing sleep problems at bedtime and addressing sleep hygiene first. If your child is sleeping in your bed, change that contingency. Go sleep with your child because it's easier to fade you out of the room than your child out of your room. Does that make sense? So when you're using this method, there are two variations here. One is the sleeping bag or futon or mattress method, and you use that when you need to be with your child the whole night. If your child has the sleep dependency where they need you to fall asleep but then they're staying asleep, then you can feel free to use a chair instead of this and leave after they fall asleep. So essentially what you're going to do here is you're going to start out in your child's room right next to your child. Some parents even start on their child's bed if there's room, or we'll bring a mattress and then we'll start everyone on the mattress or right next to them. And then over successive nights, oh there it goes, you're going to slowly start moving. I've had parents do this. This took me a while to animate, so I'm really glad that that's working though. So I've had parents being able to do this in as little as 3 nights. Other parents needed to make small changes, so small that the child really wouldn't notice the difference from one night to the next. So I've had parents use this, again, in 3 nights as long as 3 weeks. Do what works for your child. Okay, so there's also some visual strategies that you can use if your child is waking up too early. On Amazon, I found a couple different kind of visual timer things that are specific for this problem. So these little clocks turn color when it's time to get out of bed. And this one, you can't get out of bed, stoplight. When it's green, that means that you can leave your room and you can get out of bed. You want to pair these, and if you don't want to purchase one, you can put a stop sign on the door at night, and then when it's time to get out of bed in the morning, go. Anytime you're using something like this, you definitely want to pair it with rewards. And then another strategy that you can do is teach your child to engage in independent activities in their bedroom. This is where we at BACA can really help you to develop routines that they can do completely independently without getting out of bed to bother you. So some parents choose to have boxes of quiet activities, and for some kids they need a visual schedule to go along with that. Okay, here's my to-do list before I go wake up mom. And this again is an area that your team supervisor may be able to help you with.
In theory, isn't that counterproductive because that now gives you a list of things that isn't sleep to do at night?
This is for when they wake up too early. So there are just some kids that their biological clocks are going to wake them up a little bit earlier. So you don't want them to do this at night. You want them to do this if they wake up in the morning. And that can be a little bit more arousing activities, but it's still things that they can do independently. Does that make sense? So now I'm going to get to the bedtime pass. This is the easiest intervention, so I saved it for last so you will remember it. So this intervention can be used for, and also in one of your handouts, there are some example bedtime passes, and I think both of them have, they're both, these are, I should mention that these are both from the Autism Speaks websites. I love their toolkits. These are 2 of their toolkits that go kind of hand in hand. I didn't print it out today, but if you go online to Autism Speaks and look for sleep toolkits, they just printed out a new one earlier this year specific to teens. A lot of the same strategies, but some modifications as well too. So the strategies are the same, but just little small differences. So using a bedtime pass, and here are some examples. You can also personalize this with your child. It might be a fun little art project for them to make their own bedtime pass. You show the bedtime pass to your child and you explain how it works. Then you work with your child to figure out what reward they're going to get for using this bedtime pass. So now here's how it works. At bedtime, you give them the pass and you tell them the rules about how the bedtime pass works. If your child gets out of bed, asks to see you, get a glass of water, you're going to give that response briefly and then take their pass. So, hey, I want a glass of water. Cool, you can have your glass of water, but I'm going to take your bedtime pass. If your child gets out of bed after the bedtime pass is used, you take them back to bed, and with no comment, they just go back to bed, and you keep taking them back to bed as many times as they get out. In the morning, if they have kept their bedtime pass, you give them a reward that you've pre-selected with them and praise. And then eventually, as this is effective, you fade out daily rewards into like a weekly reward, and you can do something like using a sticker chart to do that. So with any kind of strategy, it could get worse before it gets better if you're using that extinction component, that ignoring component. You can see a testing phase, so be firm and be consistent. And then if you have a child that gets out of bed so many times, it's okay to start out with 2 bedtime passes or 3 bedtime passes and fade down to 1 and then fade to none. Some other interventions that I'm not going to talk about today, but I'll just tell you really briefly. For nightmares, using kind of magic, giving them a magic object that you say, this will help keep the monsters away. So this is monster spray. For sleep terrors, that's the scheduled awake method kind of is the recommended method, where you figure out what time they're having the sleep terrors and you kind of nudge them awake before to help reset that sleep clock. For bedwetting, that is definitely something that most teen supervisors and BCBAs have experience with. This is a bedwetting alarm. And then, of course, there's always medical treatments. Melatonin supplements, for example, is something that you can discuss with your doctor, as well as other medications that are used for sleep. And certainly, there are medical issues with sleep as well, too, such as sleep apnea. If you can't figure what's going on, and your doctor can't figure it out, we'll probably recommend a sleep study. I put a website for places to find accredited sleep centers. I'm not harping on Riley, I'm just, because I worked there for a year, I know what resources they had, but they do have a child sleep unit where they do these sleep studies. And you want to inquire, hey, do you have experience with kids with autism? And if not, maybe find another provider that does. I'm running out of time, but I do want to make you aware, interventions can also impact the family. So the Autism Speaks, this handout has some good strategies to cover that. And so the 3 resources, I've already shared those 2 with you. The one in the middle is Dr. Durand's clinical workbook that goes along with the Sleep Better. Sleep Better is designed mostly for parents, and then he's got a workbook and professional book that can be used with a psychologist or behavior analyst. There's a parent version, a parent workbook version, and a therapist version. And that one is called When Children Don't Sleep Well. It's pretty much this on steroids. Also, Autism Speaks, like I said, has these great handouts, these great toolkits, and they have a lot of the things that you might use to start your own sleep intervention at home. I have a whole bunch of reference studies, which most people aren't interested in, but they are there if you would like to go back and look at the research.